Well, I'll start with a quick announcement while we're waiting, which is that ICPSR, which some of you might remember, we have a membership to, and Claire has taken a bunch of classes. I know some of you have as well. They're having a webinar for their programs in summer of 2023 on November 30th. So if anyone's interested in that, I can forward you the information about it. They just sent it out via email today. So if you're interested in ICPSR summer course next year, let me know and I can send you those details. Melissa, I jumped into an announcement.
Yeah, thank you. That's great. That's great. Any other quick announcements? I know we want to squeeze a bunch in today. Yeah, okay. All right, why don't we go ahead and get started? Caitlin, are you going to organize us as we go through this?
Yes.
I'm excited.
I know and I was letting everyone know it's a little bit of an experimental format, but this is what today will look like. So we'll hear 2-minute versions of all of these presentations from GSA. I'll time folks and give you a halfway through warning. And after each poster, we'll take one question, poster or slide, I should say. And if we have time at the end for more questions, then that's great. So we'll get started with Madeline, who is a 2022 MSTAR, and I know has to hop off at 12:10. So we're going to get her in before then. Madeline, if you want to share your screen, you can go ahead.
Are you able to see that?
Yes.
Visual? Oh, awesome. Okay. So yeah, I'll be presenting today on HIV providers frameworks, the relationship between HIV and aging among their aging patients with HIV. So this study, it's situated within a much larger multi-method study to understand barriers to comorbidity management among aging people living with HIV. I'm sorry for the activity in the background. But our analysis is stemming from a qualitative piece where Abigail and another med student who is now a resident interviewed 11 physicians, case managers, and administrators as they cared for folks aging with HIV. They're located at HIV clinics in New York City and in the Hudson Valley to understand those providers' experiences and perspectives, especially around how the aging piece comes into HIV care, comorbidity management, referrals for that population, et cetera. So our analysis so far has focused on how providers are thinking about or framing those issues related to HIV and aging, because this could have implications for the care that patients receive. So the kind of central organizing theme to highlight in this condensed version of the presentation is HIV conditionality. So previously, HIV dominant forms of thinking were kind of central among providers, where HIV was the most important thing patients were coming in with. And this often overshadowed other conditions they were coming in with, just based on where folks were at that moment of the epidemic. So HIV conditionality is meant to convey how HIV is still kind of a guiding or grounding framing, but it might not necessarily take precedence in terms of clinical management or what providers are thinking about. So you can see there's one manifestation of this is the way that providers describe their patients as having kind of these longitudinal social or medical experiences related to HIV. And this is like living through is what we're calling it, but it's also an emic phrase, kind of living through this shifting epidemic. And then another manifestation is the way that providers' perceptions of what was most relevant or most important from a clinical management perspective was mediated by whether or not a patient's HIV itself was managed. So folks who had, a lower viral load were treated differently than folks who had a higher viral load in terms of where the comorbidity piece came in and how important they were. So that's the short version.
Thank you so much. That was exactly 2 minutes. And we can take a question if anyone has one.
Yeah. Take one more step.
I can't see everybody at once, but please feel free to shout out if you have.
About that a couple weeks after trying to get it first time.
I don't think she can.
All right, going once. Going twice.
I have a question. This is Jenny.
Okay. Jenny,
So
thanks.
this kind of, sorry, I turn my video off for a second, but the way that sort of living with HIV versus like living through HIV. Does that kind of match how people are talking about HIV and aging in general? Like, did this seem surprising, or does it sort of like these sort of perspectives of providers sort of match other like findings about the perspectives of individuals who have HIV?
Yeah, that's a great question. I think the living through language, I haven't reviewed a ton of the literature also looking at HIV providers' perspectives in this particular moment. Like, what does that look like in 2022? So difficult to say, but I think that would be, if, well, I don't know how much to say. I think that is possibly shared by a number of providers outside the context of the study as well, though. Just like one of the things we're finding within this study that possibly could be, I mean, generalizability isn't the goal of qualitative studies, but possible something to be aware of is providers are often taking on like a particular cohort or a particular age in terms of the patients they're aligning with, and then aging with those patients. And I think that's something that multiple providers talked about in our study, and seems like it could be consistent across other clinics as well.
It's interesting. Thank you.
Thank you.
Sorry, I was on mute. Thanks for kicking us off. That was great. And next we have Gabby.
Hi, everyone. Hold on, I'll just pull up my poster. Okay, can everyone see my poster?
Yes.
Okay. Thanks for joining us today. I'm Gabby. I'm Gabby Schiller. I'm from the department, obviously, and I'm representing my team. We did a study working some background. The hospital at home acute care waiver was implemented at the end of 2020. And we interviewed program leaders from across the country to ask them questions about this waiver that enables payment for hospital at home. And we analyzed these data from these qualitative interviews to see how these HA programs were addressing the social determinants of health. So we actually interviewed about 14 programs from across the country. So that was a pretty national representative sample. And as you can see on the right-hand side, that we had a pretty diverse geographic sample. And some themes that we discovered that hospital at home helped promote a healthy lifestyle and safe home environment. It provided engagement and care through effective communication and shared decision-making. And it helps reduce the mental health distress associated with hospital stays. And importantly for this study, there has been a lack of research on how hospital at home may address the social determinants of health. So this might be an effective way to help implement hospital at home service. My favorite quote from this was about how when you get into the patient's home and see that the cabinets are lined with progressive food, and that's all the patient's eating. This enables to have eyes in the home. So that you're able to use this as an opportunity to intervene and help the patients get the proper help that they need. Also, a lot of older patients don't want to be in the hospital, as we know this in our department. So being able to be home alongside their family was a huge benefit for patients. And we used this, as we were analyzing this data, we really looked through the 5 domains of the social determinants of health, which you can see in this. This is a figure from the Centers for Disease Communication. And we also were looking specifically at programs that were enrolling with COVID patients before COVID or not COVID. And that also was a big part of this study. I can't see the chat, sorry.
That's
Right.
okay. We're at 2 minutes now, Gabby. So if you have any closing thoughts, we can take them. If not, we'll take questions.
I just want to say thank you. Abigail was also part of this, and it was a great project, and we're still analyzing the data.
Awesome. Thanks. I see Harriet has her hand up.
Yeah, hi. Thanks so much, Gabby. Some really interesting work to think through. Did you address or get into, as part of this, how the different HAR programs are working with community providers and community-based organizations to kind of screen for, address, and to kind of, because I'm just conscious that HAR is a kind of limited stay, and then you need something sustained for after the time that somebody's been on hospital at home if you do identify social determinants of health. So did you get into that at all? with them how they're doing that differentially.
So we didn't have a specific question asking about community-based organizations, but we did ask about how these programs are embedded within the community and what services they connect people with specifically. So like under the hospital home waiver, you have to be able to provide food to patients. So that was a big part of it. And like they would use like some programs, I believe, I see Abigail nodding her head, so she could jump in here if she wants. We're also getting involved with community-based organizations to provide that food.
Yeah, I was hoping you were going in that direction, Gabby. That was as part of the requirements of the program. There had to be vendor contracts if the program wasn't itself delivering. So if those contracts weren't already in place, they were put in place around this program, and I think that did extend the reach of the program to try to sort of support the community, build community-based programs into this program. But we need to look at that more carefully too, in terms of experiences with that process.
Awesome. Thank you so much, Gabby. That was great. Next, we have Deborah Watman.
I'm going to take over the screen share. Cool. Good. Okay. Hi, everybody. Deborah. I'm working with Jenny on this project. So this project was about the role of paid caregivers in home-based dementia care. We interviewed family caregivers, geriatricians, and paid caregivers. So we conducted triadic interviews. There were 9 triads, and we're really trying to find out more about what the paid caregivers' role were at home. And I want to just take a second to talk about how we portrayed the data, because I think that was the challenge in how we portray this qualitative data. So as a whip, I'm going to take a second there. So the big center chart over here on the left side, we pulled out quotes that we felt described the triad. And on the right side, we summarized it. And so there are 9 triads. And on the right over here, it's a little bit tricky to, okay, so this chart basically describes each triad a little bit more. On the x-axis, we have how long each paid caregiver worked with each client in terms of years. And in the y-axis, it's how much time each paid caregiver spends with that client. And there's all different shapes and colors, and they represent different things. So it shows whether or not these triads were with an agency, whether or not they died over the longitudinal interviews, time spent that we interviewed them, and whether or not there was a change in paid caregivers. So like, for example, if you look at number 6 over here, we see that they were living, we see that there was a change in paid caregivers, that they worked with the client for 6 years. And that number 6 actually corresponds back to this number 6 in the qualitative quotes. So that was the one that said we're both alpha males. The paid caregiver was describing the interaction between the paid caregiver and the family caregiver there. So that's how we described the data. And we learned that each triad was really unique. There were nuanced paid caregiver arrangements. They were all very different, which just points to the fact that we are looking towards person-centered dementia home care, that formal care plans don't really say that right now, but we're trying to get more towards this unique caregiving. And that's it. I'm at 2 minutes.
Thanks so much, Deborah. All right, I see lots of appreciation for that visualization in the chat. Does anyone have a question? I'll ask one. So I first of all love some of these quotes. They're awesome. I'm the CEO in particular. I thought was great. And I'm curious, you mentioned that family caregivers are the main drivers of the paid caregiver role. How do you think situations with this triad might differ from folks who, for example, don't end up getting access to paid care, and what kind of takeaways from this project would you think are important in terms of care access?
Interesting. I'm not sure I fully understand, but I think the family is like always providing so much care, no matter or like whether or not they have a paid caregiver. They all had paid caregivers, but like it didn't matter how long that paid caregiver was there. And I think maybe like providing more resources to these families, because no matter what, they are the ones who are really driving this care. I don't know if that answered your question, but.
Thanks. Yeah, it gets at it. All right, awesome. Thanks so much, Deb.
Yeah, thank you. I'll stop.
All right, we have Jenny next.
Can you see? Is that okay?
Looks great.
Yeah. Okay. So, so this was a project. This was sort of like my summary. It was a paper presentation about a project I presented at WIP before, but we called it Continuity Matters: The Impact of Home Health Aide Continuity on Health Outcomes Among Home-Based Long-Term Care Clients. And so this is the project I've described before, where partnering with VNS, we looked at the individuals who are in the VNS managed Medicaid who get home-based long-term care paid for by Medicaid, and linked their information to information about the actual individual paid caregiver who came into the home. And, you know, because those people enrolled in Medicaid have assessments on essentially every 6 months, we sort of looked at those 6-month periods, looked at how many home health aides they had during that period using this Bice-Boxerman index. And then we looked at outcomes. So difference between, or the relationship between health outcomes or health status at the one point in time, and then 6 months later, and looking at the relationship between aid continuity in that period and those outcomes. And so this just presents some of the key findings. So first, you can see the graph here looks at the continuity scores related to how much care people got. So people who received less care, like 3 hours a day, less than 3 hours a day, in general had pretty good continuity. But the more care people received, the lower that average continuity was, which makes sense. There's just more people coming and going. But notably, those people who had the highest need were also the people who were the sickest and the most cognitively impaired and had, you know, the most going on. They also had the worst continuity. And when we looked at the relationship between outcomes, we looked at a variety of outcomes, but the idea was to just sort of not just think about the functional outcomes, not just think about things like falls or ADL changes, but also think about ways that home health aides may contribute to psychosocial health. So things like depressive symptoms or self-rated health, as well as utilization. And what we found is that individuals who had in this 6-month period better aid continuity were less likely to have falls, more likely to report improvement or stabilization of their ADLs, and they were less likely to report depressive symptoms, or more likely to report an improvement in their depressive symptoms. And so overall, I think that, you know, the take-home messages are that home health aide continuity is lowest among these people who potentially could benefit the most from continuous regular aid care, and that the presence of home health aide continuity, so more care from the same people over time, was associated not only with better functional outcomes, but better psychosocial outcomes, and it didn't impact utilization. So that's all. Do people have questions?
Jenny. I see claps from Crystal and a hand raised from Harriet.
Thanks, Jay. This is really interesting. Just a couple of questions about the continuity score. How is that derived? So if you have more home health aides, do you necessarily have less continuity, or is it continuity kind of over time rather than any one point in time? And I guess relatedly, what did you adjust for in the analyses to make sure that we're not just seeing discontinuity as a surrogate of people being sick, and therefore as a surrogate of having worse outcomes?
Mm-hmm. So a couple of things. So first, for continuity, we use this Bice-Boxerman index, which is sort of like dispersion around a mean. We are still kind of going back and forth if that makes sense in this high continuity or high needs group, where there's more people involved just sort of by definition. But that's how we used it. So it's somewhere in the middle, right? So, you know, if you have 2 people, your continuity is not like half as good as somebody who has 1. I mean, they're looking at sort of the relationships around the single person. but it's tricky. It's kind of the standard way people did it. Like Amy and others in the group like did a paper recently that used that Bice-Boxerman index to look at continuity. So it's sort of the standard of how you do it in healthcare, but it is a little different with AIDS. And so we're trying to kind of wrap our heads around that. And then the models, you know, we were able to find it. We had a good, pretty detailed functional assessment. So we controlled for function. We controlled for cognition because that was pretty detailed. We controlled for, you know, age and gender. We looked at some other variables. There's a lot that's asked in this clinical assessment, you know, information about, we controlled if people live alone. Poverty kind of comes in there, though it's interesting because it's a Medicaid population. So we did our best to control for things. I mean, I think to me, the fact that you see a variety of continuity, like a range in continuity at all levels of need, speaks to the fact that there is variation in there, and it's not just about how much you need. There's something else going on. But a limitation of this is that we really couldn't capture anything related to the aides themselves, right? So like that was a problem. We were able to capture some things related to families, but not really that family caregiving, you know, what they were doing there. So this is the Pepper pilot, and I think like it's one of those good pilots where it brings up a lot of great questions that you hope to answer in the future.
Thanks, Jenny. We're miraculously doing okay for time, so we'll take another question from Liwa.
Yeah, sure. I think thanks, Jenny, for the nice presentation. I'm just curious, like, you know, in the right panel of the table, you reported the estimate of the association, but I was just curious, what's the magnitude of the association is measured by 1 unit increase of the continuity score, or like
Yeah. So the continuity score is right. Sorry. Yeah. Lots of in between info I left out. So it goes from 0 to 1. So that's sort of like continuity score. And, you know, that is absolutely a good point. It's like, what is a clinically significant difference in continuity, right? And that is also tricky because, you know, this continuity score hasn't really been used in this home health population. And so as we've been thinking about how to present the results, like the group has sort of gone back and forth, because there was one person who was like, we need to like write a whole paper just about like what this score possibly means here and what it's getting at. I think, you know, so that's tricky because you don't know, like, there's like not an objective, like this is important or this is not important. We did map it out, but there's so many numbers. So it's like over 6 months, like those people with high, you know, with the lowest, like with the most aides had maybe 10, 12 aides, thousands of hours. So even like I did try to create a visualization where I'm like, this many hours, like what does it actually look like to have this score? And it got super tricky. But I think that, so those are the reasons the score is hard to use. I mean, I think the reason it's good is because so much with home care depends on the individual parts of the situation, and continuity is a cool concept because lots of people can benefit from continuity regardless of what your needs are, if you have dementia or whatever else. So I think it's getting at an important concept, and I think, you know, there's more to do.
Thank you.
Thanks, Jenny. Next we have Rebecca.
Okay, I'll just share my screen here. Okay. Okay, so this is a study that we did as part of RP2, and it's looking at the impact of widowhood on survival in people with serious illness, specifically dementia, heart failure, and cancer. And this is part of a broader project looking at the impact of disruptive events on the disease trajectories in serious illness. So we're looking at a surgical event, a medical event, and this is a social event, widowhood. And the widowhood effect refers to the increased likelihood for a person who recently lost a spouse to die. And we were looking to see whether that had impacts in people with serious illness, because it's been shown to have impacts on mortality and overall general health in the general population, but there hasn't been much data in serious illness. And so you can see here, we looked at these 3 different illness categories: dementia, heart failure, and cancer, looking at the crude mortality rates for these populations when, you know, the average age around 80 is when widowhood occurred. And so that's what we used as the age for these mortality rates. And you can look at the relative risk associated with widowhood. And we looked at people who had experienced widowhood within the last year and people who had experienced widowhood further back in time than that. And you can see that the risk of dying increases for people with dementia and heart failure in the year following a widowhood event. So for dementia, the relative risk is 1.4, and for heart failure, it's 1.5. That effect is persistent after 1 year, but diminishes. So for dementia, it goes from 1.4 to 1.2 for a relative risk. And for heart failure, that relative risk goes from 1.5 to 1.4. Interestingly, we didn't observe an increased risk of mortality in cancer. You can see there that widowhood within the last year had a relative risk of 0.9, and after that, it had a relative risk of 0.73. So those were kind of some interesting and surprising findings. And overall, the main findings are that the widowhood effect is demonstrated in dementia and heart failure, but not in people with cancer. And also that, in dementia and heart failure, this widowhood effect is persistent but diminishes after 1 year. And overall, these findings suggest that the widowhood effect may be most pronounced in illnesses like dementia and heart failure that have prolonged periods of poor function, unlike cancer, which has a more rapid decline until death. And so this might be consistent with the potential mechanism of the widowhood effect on survival being a loss of caregiver support. And the diminished effects beyond 1 year in the survivors might be due to greater resilience at baseline or adaptation to change in circumstances that happens after widowhood. Interesting, the lack of observable effect that we saw in cancer might be due to this relatively rapid decline to death that occurs once function starts to deteriorate, and it might be creating a kind of ceiling effect whereby you just can't see an increase in mortality once death is more imminent. It also might be that cancer, these change in function that happen as cancer progresses, it's associated with a very clear prognostic index, and it also can therefore help mobilize acute other resources, whether they're informal caregiving support or other services like hospice enrollment that might be mobilized in cancer. And so it just, begs the question whether other kind of community or palliative care interventions might be helpful to diminish this effect in dementia, heart failure, or other illnesses.
Thanks so much, Rebecca. Does anyone have a question?
I have a quick question. Thanks, Rebecca. How did you evaluate the diminishing effect? You could see thinking of it as a dose response and a lot of different ways of doing it. It looks like it's just a binary more than 1 year or less than 1 year, but is it like did you do an interaction, or it's surprising that these small differences really are actual declines. So I'm just curious what that was.
Yeah, so we don't have an interaction term. We did account somewhat for the fact that just because you survive another year, you're just more likely to survive in general. So we did try to account for kind of the survivor effect in general, but it would seem to be a more consistent trend. And we did these analyses several different ways. And so you're absolutely right that it's possible that this might be, the same effect persisting, whether it's diminished or not. Although when we did the analyses in a variety of different ways, we kept getting really consistent results.
Okay.
If that helps to answer your question.
Great. Yeah. Thank you.
Thanks. And I see Liwa's hand.
Yeah, just to follow the nice presentation, Rebecca. Just to follow Melissa's question, because I was also about to ask, how do you really test the diminishing dissociation? But here I was also curious, like when you say the relative risk for cancer is also seems decreasing in terms of the number. But I was wondering, have you ever tested the statistical significance, like?
Yeah, we have done this is like maybe the 20th iteration of these results, and it's kind of like the last thing that we've done, and we kept getting actually kind of surprising. Our initial results showed, like in diseases like cancer, that widowhood was protective, and so that didn't seem to make any sense whatsoever. And so we've done the analyses in several different ways, and so I think we can't say with confidence that it's like a reduced risk of dying, but we just don't see in any of the iterations that we've done of the analyses, we don't see any increased risk of death in the patients with cancer that we selected.
So here, dementia and heart failure, those as relative risk is significant, right?
Yes, Yes.
But not those 90, but for the cancer, 0.9, 0.73, are those ones significant as well?
So the 0.9 was not significant, and then the 0.73 is kind of borderline.
I see. Got it. Thanks.
Thanks. And we'll take one more question from Harriet.
I'm just thinking through, I think this is really fascinating. I'm thinking through the kind of potential protective effects and caregiver networks and things that might be mobilized. Were you able to get at transitions in care? Just thinking through if somebody is widowed and they have cancer, the protective effect could be that their existing care network wasn't particularly good. And then when the person died, suddenly the daughter or the son or somebody else gets involved, or they transition into kind of assisted living, or all of these kind of other things that might be happening, and whether that's differentially available in cancer versus other illnesses, a little bit to what you're getting at. So are you able to kind of look at those and think through, are you planning to think through that more?
Yeah, that's kind of like exactly where we're heading, because we excluded anyone who was in a nursing home at baseline, although we did account for people who maybe had transitioned to a nursing home during the course of the study. There was actually a fairly small proportion that wouldn't have been statistically that helpful. One thing that we're doing right now is looking at caregiving hours received before the widowhood event and caregiving hours received after widowhood event, and seeing if there's a big change to see if that could support a hypothesis of this being related to a change in like how much care is required. And then another thing that actually I should really be looking at whether anyone enrolled in hospice.
Yeah.
Would be another interesting avenue to go down. So that's a good thought. Thank you.
Thank you so much, Rebecca. That was great.
Thank you.
Fred.
Oh, I'll stop share.
Oh, Fred, you're on mute. Oh, there you go.
Yeah, I'm sorry, bear with me. There we go. Can you see this?
Looks great.
Okay, so this was a symposium presented by Hannah Thompson, who is a occupational medicine resident, Catherine Ornstein, Will Hunk, and myself at GSA. So I'm trying to collapse 3 presentations into one, and I'm going to do this in under 2 minutes, I hope. So the study population is the World Trade Center general responders, and these are folks who are involved in the rescue and recovery effort in the aftermath of 9/11. Previous to these studies here, we had developed a frailty index, which is a way for us to gauge the risk for frailty in this population based on the deficit accumulation model. We found that a third of the general responders were frail, despite being younger. So these 3 studies here are a continuation of that study. The one on the left here looked specifically at frailty trajectories, i.e. the change in frailty index over time. So we use longitudinal data collected from 2004 to 2020, data that are collected through the routine visits of these patients in the World Trade Center Health Program. And we found that there were 3 distinct frailty trajectories as shown here with 3 different slopes. And the frailty trajectories were associated with risk factors such as the severity of the World Trade Center exposure, i.e. The amount of the duration of time one spends working at the site, exposure to dust cloud, among others. It was also associated with sex, education, income, and occupation, particularly those who work in the constructions prior to 9/11. In the second study, we looked specifically at polypharmacy in this population that's shown here on the right. In this population, the mean number of medication was around 6, with greater than 55% of the patients having met the definition of polypharmacy. And polypharmacy was associated, for example, with obesity, specific conditions that are certified by the World Trade Center, such as cancer and pulmonary diseases, and associated with frailty index as well. What's not shown here is a table looking at the association between false risk increasing drugs, and there was associations as well with specific World Trade Center conditions and frailty index. And the third study looked at a small pilot, a cohort, in which geriatric assessments were done prospectively. And in this cohort, frailty was found to be associated with obesity, false risk, fear of falling, ADL dependence, as well as World Trade Center related certified conditions and mental health certification. So the studies are ongoing. We're expanding our cohort in the next 3 to 4 years with a target of 400. We will be assessing geriatric conditions to better determine these associations and risks for frailty. We're expanding our analyses for trajectories and polypharmacy, as well as developing an intervention to decrease polypharmacy, inappropriate prescribing in this population as a pilot intervention in the next few years. And I will end with that. Did it come under 2 minutes?
Not quite, but close enough. Thank you, Fred. That was great. And you all will hear a lot more about the new grant in an upcoming WIP. Li Hua, I see that you have a question.
Yeah, thanks, Fred. A very interesting presentation. I'm curious, like there are 3 distinct trajectory in the figure. I'm not so sure, like how do you clinically label those three groups?
Yeah, so we have specific labels. So we call this group, I think, low frailty index, high frailty index, and sustained increased frailty index groups. In the literature, which are done looking at aging cohorts, the nomenclature is quite different depending on which study you look at. But I would say that for the most part, many of these studies are finding that there are 3 or more different distinct trajectories in the aging population. And frequently, there would be one group that had a larger slope of increase in frailty over time. And similar to what we have here. And I would say this is perhaps a group that is the most interesting to look at in terms of identifying risk factors that can cause this accelerated increase in frailty and perhaps potential areas of intervention.
I was also curious, like because you also identified some of the covariates with WTC exposure, sex, education, income, and occupation. Were these covariates associated with identifying those trajectory, or those were just factors impacting the trajectory of frailty index? Because I'm just curious, because I would guess that you used a probably latent class model to identify those 3 different groups, right?
Right. The trajectories were determined by the latent cluster mix models, as you mentioned.
Yeah.
We compared between the groups. So the red group was used as a reference group. We did a regression model comparing the blue to the red and green to the red.
Okay.
Yeah.
I see. So those factors identified here mainly are the factors predicting the distinct 3 groups, right?
That's correct.
Okay, got it. Thank you.
Thanks so much, Fred and Li Hua. All right, next we have Abigail.
Okay. How's that? Can you see the slide?
All of the slides. I don't know if you want to swap to.
I think that's okay because I'm just focusing on this this one that lays out the key identified themes, but you can sort of see what probably like helpful related information on the left. So this was a descriptive presentation led by Emily Franzosa, who is unable to be with us today due to her policy and aging fellowship. So she led on this analysis, and I'm sharing it here. So this is part of, as Gabby said, this larger qualitative. Are you seeing my notes now? Did it shift? Okay. This is part of a larger qualitative evaluation of the hospital at home acute waiver program. And Gabby nicely presented some of our methodological background. So that applies here too. So overall, we were looking at the implementation of this waiver, this CMS waiver version of the hospital at home program amongst programs that were approved to deliver the program using the waiver, thereby getting reimbursed through CMS for hospital at home. But this specific analysis was looking at the question of geography. So how did geographic factors shape the implementation and delivery of the waiver program? And the question's pertinent because part of the CMS waiver requirement is that patients are able to, if they're receiving the program in home, they're able to return to their hospital-based, sort of the parent of the program, the hospital associated with the program, within 30 minutes due to decompensation or needing hospital-based services. So as a result of that requirement, we found 2 themes of adaptation and 3 themes related to the challenges that geography provides in delivering the program. And so this slide depicts sort of at the higher level those thematic areas. So as for adaptations, we found that programs actually in response to the challenges were realigning some of their program goals to meet the waiver requirements. So what that means is that programs were trying to figure out if they could, for example, construct hospital-based services in what one provider called separate nodes. So sort of building out of their primary location so that they could have more flexibility to meet that requirement for a greater number of patients. They were also using creative leveraging of internal and external resources. So again, trying to find meaningful partnerships, sometimes with community-based services, to pick up on Harriet's question, for example, with paramedicine, also using telehealth strategically so that they could sort of optimize the geography issues. But this was also, responding to challenges, and other programs couldn't really overcome challenges like managing a resource-intensive model and rural staffing shortages, capacity shortages that provided some barriers. They also expressed equity concerns, particularly around rural enrollment for individuals who were frail and would be good candidates for the program, but might have created an additional barrier to getting them back into the hospital in time. How are we?
Great, you're good.
Okay.
Thanks. Does anyone have questions for Abigail?
So Abigail, thanks for this. This is really interesting. I guess, what do you think you would do? It doesn't seem that the kind of rural and equity concerns are surmountable. Like, what would you suggest in terms of implementation that would address the concerns, the challenges?
Yeah, I mean, I think one point we make, or sort of our team found to be a potential type of intervention, we didn't express this as strongly in this initial sort of evaluation paper that was recently published, but I think CMS could look at some of the requirements. These are not requirements for the hospital at home model, they're requirements for this CMS version. So with these kinds of challenges with geography, of course, making sure patients are well covered for whatever happens when they're home is important, but maybe this 30-minute geography issue could be handled in other ways, or that particular requirement maybe could be augmented in the list of criteria for the CMS version of the program. So that's one perhaps form of intervention. And then the other maybe is leaning into some of those adaptations maybe, and trying to encourage more sort of a partnership model, perhaps, so that, if you have a lead program who's been approved for the program, they're the ones sort of on the hook to deliver emergency care if there's some sort of acute issue. Perhaps there are strategies to partner with more sort of local, urgent care. They aren't the lead on the programs, but they're recognized as approved partners to deliver components to meet some of those requirements. So I think it was sort of those kinds of things that might help. But I mean, that said, as you say, some of these challenges around capacity and shortage are obviously, sort of more structural and, deep ones to handle. The program sort of at some of the conditional, mercy of those things.
Great. Yeah, that makes total sense. Thank you.
Yeah.
Great. Thanks so much, Abigail.
Pleasure.
And lastly, Emily Shu, who is a wonderful 2021 M-Star who stuck around and has continued to work with folks in our department, is in clinic right now. So Jenny's going to pinch hit on her behalf.
Right. Great. Thank you. And Emily did an amazing job prepping for this. So I'm actually going to read her thing. Maybe one or two things. I'm just going to read her because she really pulled together all the results and I want to share that. So many homebound older adults and their family caregivers rely on home care workers to provide care in the home. In this study, we looked at the role of home care workers in caring for homebound patients during the height of the COVID-19 pandemic, using medical record notes from the Mount Sinai Visiting Doctors Program, and examined how disruptions impacted patients and their families. Using qualitative thematic analysis, we found 3 themes. Home care workers experience shifting responsibilities, including taking on new medical tasks and additional social tasks. For example, here we see with theme 1, his home health aide had been stopping by a school, giving out free meals to hungry New Yorkers. Patient has been trying to stay home and avoid going out, risking getting sick. The second theme was family caregivers were impacted when home care worker services were stopped abruptly, either by family choice or by home care worker precarity, as shown in the second quote. So the aide is afraid to ride the subways, so quit. Agency was having a hard time finding someone. They asked if family caregiver could help out, but she physically can't change her sister. And then number 3, COVID-19 related regulations about when home care workers could return to work created gaps in care, like in the last quote. So the home health aide tested positive for COVID. Agency removed home health aide and will not put another home health aide in for 14 days unless the patient is tested. She regularly has 24-hour care and she cannot be alone. So in sum, these findings suggest a need to strengthen the stability of paid caregiving, including more robust training and policies that support continuity of care during emergencies. So thank you all. I will take questions on Emily's behalf, but this was a really cool project and she really took on this piece of it, looking at home care workers, worked closely with Emily Franzosa, who couldn't be here either. But.
Thanks, Jenny. Does anyone have questions? All right. Well, thank you so much, everyone. That was wonderful and even more efficient than I could have imagined. So I appreciate everyone really doing it in 2 minutes. Does anyone have general thoughts or questions that came up during posters that they didn't have a chance to say?
Can I just put in a general plug for GSA? Like, I had a really great experience at GSA this year. And I think that like GSA, I don't know. I think there's a group of us who always like to go, but there's just so much going on there. And I think that it's a great opportunity, unlike something like AGS, where the majority of people are doing posters and that the sort of symposium format is pretty rare. At GSA, if you have an idea, if you have people who are working on, a similar line, I think it's a really great opportunity to pull people together. And I think like there's lots of people there who are interested in a lot of different things, and the act of kind of being there and presenting and seeing all of this come together is just very cool. So anyway, that's my GSA plug, but I think everybody should go next year. And it's in Tampa, which is not great, but either way, you should still all go.
It's definitely not as cool as Indianapolis. I mean,
I have to say, Indianapolis was kind of awesome.
thanks, Jenny. I feel like everyone I've spoken to had a really amazing time there. So that's great. Any other thoughts? Okay, a couple quick reminders about upcoming abstract submission deadlines. Speaking of AGS, theirs is December 1st. And shortly after that, January 12th is Academy Health Arms abstract submission deadline. So just a heads up about those. And is there anything else that folks want to announce or cover while we're here?
Well, I would like to thank you for organizing this. I think this was a really interesting way to showcase all of the work you guys have done and presented at GSA. So thank you, Caitlin. I think it went beautifully, and we should try to think of other times, whether it's focused on a annual meeting or whether it's just in general. We do a blitz every so often. So thank you so much for organizing everyone and keeping it all on track. This was really great.
Thanks. Yeah, it was fun. I was nervous that it would be way too long, but it was great. So thanks everybody for being in this little experiment. Awesome. All right. Well, enjoy the 7 minutes between now and all of your next meetings. And I'll see everyone soon. Bye.
Thanks, everyone.